Good morning, good afternoon, good evening, everyone, and a very warm welcome to this IACH webinar. And this is a special roundtable dedicated to the key highlights and data presented at the 2025 annual meeting of the International Academy for Clinical Hematology. I'm Mohamed Mouti from the Sorbonne University and Saint Antoine Hospital in Paris, in France, and it is my great pleasure and honor to moderate this round table with some great friends and colleagues who are leaders within the ICH, and they will summarize the annual meeting findings. So over the past few days, I think the ICH community once again gathered experts from all around the world to discuss the most recent advances across the field of hematology, from transplantation and cellular therapies to myeloid and lymphoid malignancies, immune complications, but also innovative supportive care. And today's session, which is like 48 hours after the end of the meeting, is designed to bring those insights directly to you in a concise and interactive format. And you will hear from our distinguished panel. They will share their personal take-home messages. They will try to contextualize the new data, but also discuss how these findings may influence our practice, but also future research directions. As always, the spirit of the ICH is about knowledge sharing, collaboration, and of course, improving patient outcome. So I kindly invite all participants to engage actively, to ask questions, share perspectives, but also keep the dialogue going beyond this session. So let's get started and dive into what truly matters, translating the science and debates of ICH 2025 into better care for the patient. So Dr. Annalisa Ruggieri from Milan, welcome and thank you for joining. And by the way, I'd like to congratulate again Dr. Ruggieri because she received the Christian Caillot Excellence in Clinical Research Award. We're fortunate also having the secretary of the ICH, Dr. Bipin Savani from the Vanderbilt, and also Dr. Savani received the Hannah-Jean Coury ICH Award for Excellence in Research. Of course, it's a great pleasure to have Professor Karfan Dabaja from Mayo Clinic, who actually the co-leader of the Colim track controversies in lymphoma, and he's in charge of the lymphoid malignancies. And last but not least, Professor Arno Nagler, the vice chair of the IACH, and he's, let's call it, my partner in crime in this ICH adventure. So thank you all for jumping in and for accepting this invitation. And I know Dr. Dabaja has a very tight schedule. He has to start again his clinic of the day. So let's address the first topic when it comes to lymphoid malignancies. And Mohammed, let's start with CLL. There was a session where CLL was discussed, and maybe if you can give a brief summary to our audience about state-of-the-art management of CLL, especially that now outside the first generation BTK inhibitor ibrutinib, we have acalabrutinib, we have zanubrutinib, and last but not least, pirtobrutinib. So covalent versus no covalent. The floor is yours.
Oh, thank you, Muhammad, for this invitation, and it was a true honor. And I want to congratulate you and all members of IACH for this successful meeting. I was particularly impressed by the science that was discussed, the findings, the up-to-date information, and also really by the attendance, particularly our young rising stars, the new generation of leaders, fellows from different parts of the world, fellows in training, I meant, and so clearly a successful meeting, and by all means. So for chronic lymphocytic leukemia, I would say that there were two outstanding speakers that were invited, Dr. Talha Munir from the UK and Dr. Farouk Awan from the UT Southwestern Medical Center in Dallas, Texas. I think the topics that were really discussed and brought up to date were the question of time-limited therapies versus continuous therapy. That was certainly the theme for what we call nowadays time-limited frontline therapies. We're discussing patients, and obviously there is not a universal treatment that fits all here, and we have to take into account patient preferences and those discussions. And really, care has to be coordinated with the patient preferences in mind. But certainly, update on measured studies that have looked into the concept of time-limited therapy, whether those were the Amplify or the UK FLAIR study and others, and certainly continue to show impressive data where, in my opinion, soon MRD assessment of CLL will or need to become the standard incorporation incorporated into the treatment strategy for CLL. The other discussion was from Dr. Awan, where we were looking at the different management of patients who have relapsed or refractory CLL, looking at the entire spectrum of what is approved and what is promising therapies in clinical trials. Obviously, discussion of if a patient is to have failed covalent BTK inhibitors, what is the role of non-covalent, and also the role of BCL2 inhibitors and also CAR T-cell therapy, and certainly highlighting some of the important data that has emerged still in clinical trial, acknowledging that it's not yet approved, data like bispecific antibodies such as epcoritamab and the role that it plays in those patients. Certainly, I would say that those were the main discussions. There was also some discussion among cases of challenge disease like Richter transformation and what really represents a good treatment option for those diseases, and really how CAR T-cell therapy, although arguably not within the label, still playing a significant role for treatment of those patients who failed conventional therapies for Richter transformation. So that kind of was the landscape or the theme for CLL in IACH.
Thank you, Mohammed. Wonderful summary, very straightforward. And obviously, this issue of fixed duration therapy was also debated not only in CLL, but obviously in all other diseases. And I have myself presented in one of the sessions the use of MRD to guide therapy in multiple myeloma. But I think you brought something of great importance, which has been neglected for many years because it has a very dismal outcome. This is namely Richter syndrome. And of course, this is a terrible situation. But Professor Nagler, in the plenary session, you presented the use of CAR T cells in Richter syndrome. So maybe if we can give a few highlights on this, especially that, as far as I know, there are no approved commercial CAR T cells for Richter syndrome, but still the results are quite convincing. We need your microphone, Arno.
Okay.
Yes.
Thank you, Professor Moti. So first of all, congratulations for this so important meeting, and also for Hematology Without Border. I was very much impressed at the end of the meeting, two physicians from Mozambique that I hardly know on the map where is it, came to us and, want a photo and also discuss without medical issue in Mozambique. And you were so kindly offer because they were young to join the IACH. So first of all, congratulations. As for Richter transformation, yes, it's out of label. So we had some studies and result on point of care CAR T cell in Richter transformation. We compared 30 patients with Richter transformation that received the CD19, our CAR T cells, compared to large B-cell lymphoma and transformed indolent lymphoma. And about 40% of this patient was with P53 and unmutated and stage 4 disease. And we show that we can cure, not cure, but have about 30 to 40% 3-year overall survival and about 50% response rates with about 30% CR in this devastating disease that is no other option beside allogeneic transplant, which also is with limited success, and found out that the response to 1 month and then the toxicity ICANS is in multivariant analysis correlate. And then we went and were able to establish a consortium of 6 centers, and we got the result of about 50 patients with CAR T cells in Richter malformation. Out of them, 27 were academic and the other commercial, with similar results. So CAR T cells, there are data from MD Anderson in which they start to combine, for instance, ibrutinib in CAR T cell for Richter transformation. So I think that CAR T cell, of course, Richter transformation is not the best indication for CAR T cell, but for this devastating disease, I think that CAR T cell can have some good news to a selected patient group, especially if they achieve CR before the CAR T cell. Then the results are maybe up to 57 or 60% overall survival. Thank you.
Thank you, Arnon, for sharing this important experience, which of course is of great useful use to the community. And that brings me to a broader question, because immune therapy was really the key word during this IACH 2025 annual meeting. And the debate when it comes to immune therapy is not only about cellular therapy, and we had an amazing plenary presentation from Professor He Huang from Hangzhou in China, showing the tremendous advances that are now ongoing in the field of CAR T cells, not only in terms of next generation constructs with dual targeting, with armored CAR T cells, but now opening the indications, and he showed data in lupus. We had questions about the use of CAR T cells actually in chronic GVHD, and we'll come back to chronic GVHD in this discussion, but also in vivo CAR T cells. And on the other hand, we had also a great symposium about immunotherapy with bispecifics, and that was focused on myeloma, but this is actually also true in lymphoma. Dr. Dabaja insisted on this, and we had also several presentations in the lymphoid malignancy. So here my question to the panel, maybe to you, Mohammed, and then I'll ask Bipin and Annalisa, because they are more on the transplant and myeloid part, where this competition is less relevant, but still you're seeing these patients. So Mohammed, how do you view today not the competition, I would say, but the synergy between all of these immunotherapy tools, namely cellular therapy, CAR T cells, but also bispecific antibodies, because actually they go together. I'm not opposing. I try not to oppose, although some patient may not be accessible to one versus another.
Yeah, no, thank you, Mohammed, and I totally agree. I think that at our center here, Mayo Clinic, Florida, we have really tried to see them not as competing strategies, but complementary strategies. And I think that there will be more emphasis in future research on how do we really incorporate that. There are some patients for which perhaps the bispecific is the way to go. There are others who probably would benefit from the CAR-T. Advantages of the CAR-T, I would say, is a one-time treatment, and that's it. With bispecific, there is certainly more prolonged, protracted treatment course. So there are pros and cons also in terms of cost, ease of administration.
Mohammed, sorry to interrupt, but I think you raised something of great interest to the audience, the practicality. So can you summarize the profile of patient who one would think, I would rather go to CAR T cells if available, versus I would rather prefer bispecific antibodies even if CAR T cells are available?
Yeah, so let's discuss here, for instance, for large B-cell lymphoma, right, or high-grade lymphomas. CAR T-cell therapy have indications in primary refractory or those who relapse within less than a year. We have two products there, axicabtagene ciloleucel and lisocabtagene maraleucel. And we have also the 3 products indicated for second line and beyond, meaning third line onward. And those are the previous product I mentioned, in addition to tisagenlecleucel. So certainly for the patient who have primary refractory large B-cell lymphoma, I would say it's clearly that CAR T-cell therapy is the way, in my opinion, to go. There is no indication at the present time for bispecifics there. When it comes to those who fail 2 or more lines of therapy, I would say that probably those patients who could have more comorbidities would be favored to go into the bispecific. They have a much more friendly user-friendly toxicity profile. They don't tend to have serious side effects, for instance, immune associated neurotoxicities, which are normally seen with the CAR T-cell therapy. So I would say the patient performance status, the patient age is not necessarily a limitation. We have published in collaboration with many others that patients who are 80 or older still benefit from this type of therapy, but certainly those will be the patients where I would favor to go for a bispecific. Now, if a patient gets CAR T-cell therapy, because that's what was offered, and relapses, I think bispecific have shown to have efficacy after CAR T failure. So there is data on epcoritamab and glofitamab showing CR rates in the 30 to 35% or so. So certainly those could be indications at that time. If a patient fails bispecific, CAR T-cell therapy has activity also. So I would say that probably in the United States, the main reason why some patients get one or another is availability. If patients live in more rural areas, in less specialized centers where there were no existing platform of bone marrow transplantation, probably those patients are more likely to get a bispecific than CAR T-cell therapy. In other indications, I would say for diseases like mantle cell lymphoma, in the United States, the indication is for CAR T-cell therapy patients who have relapsed refractory disease. In Europe, they have to have failed BTK inhibitor and other. So those are certainly the indications for CAR T-cell therapy in those diseases. I would say that it's a little bit of a debate in terms of if a patient failed BTK inhibitors for mantle cell lymphoma in Europe, what else would you give after BTK inhibitor failure to be able to justify CAR-T on the third line therapy? That's an area where probably you will see more pirtobrutinib added there. You will see more other therapies to justify the, because in a way in Europe it's kind of in a third line setting, give or take. In the United States, the label appears to be more broad, relapse refractory, without mentioning BTK inhibitor, even though 90% or so of the patients were exposed to BTK inhibitors in the major studies like the ZUMA-2 study.
No, I'm glad you mentioned the sequencing between CAR T-cell and bispecific, because this is the same issue we're facing in multiple myeloma. And we had a discussion during the meeting about this. And actually, indeed, in multiple myeloma, whenever possible, one would recommend to try the anti-BCMA CAR T-cells, initially ide-cel, and now more and more people are moving to cilta-cel because of the long-term follow-up data showing more than 30% plateau of PFS published in the JCO actually in the months of June, and then try to salvage with bispecific antibodies, especially that now the anti-BCMA bispecific antibodies, we started with teclistamab, which showed great results, elranatamab, amazing results, and last but not least, the new kid on the block, I would say, is linvoseltamab, which has just been approved with results even more remarkable. Obviously, it's difficult to compare across trials because these are mainly single-arm trials. But again, the sequence is looking very good. But also during the meeting, we debated about the bridging with bispecific to go to CAR T cells, because obviously it's always good to reduce the tumor load before going there. Dr. Savani, what's your view on all of these issues? And of course, Vanderbilt is extremely active in the cellular therapy arena.
Yeah, first of all, thank you so much, Professor Moti. This was one of the best clinical meetings. Interaction was so solid. We had a speaker, authority in the field, and we had a early development career faculty waiting for opportunity, step up in the ladder. Those kind of combination was there. So I would recommend all faculties or fellows, resident, early in their career to come and attend IACH meeting, where you get lots of opportunity and a connection with people, authority in the field. So in terms of...
And you would agree the location in front of the Eiffel Tower and the social event, but also the hospitality were great.
So despite we are close to metro, close to Eiffel Tower, I noticed that on Thursday, Friday, and Saturday morning, all session, both hall A and hall B, were full. So that was impressive. I did not realize, and look at the attendees online right now. We have solid attendance despite short notice. So
Absolutely.
in terms of our program, Vanderbilt VA transplant cellular therapy program, we do around 450 to 500 procedures. I don't treat with bispecific because I'm part of BMT CAR-T program. Lots of CAR-T patients, lymphoma predominant, majority of that approved CAR-T, Lysocell, Yescarta. We don't use anymore Kymriah, but there are selected patients, they go on that kind of drug with less high comorbidity and older adults. But this is how we are structured. For transplantation, numbers of lymphoma patients receiving allotransplant are significantly declined, significantly. I need to count, despite high number of allo we do, combined program around 250, 300, very rarely we do diffuse large B-cell or mantle cell lymphoma advanced CAR-T therapy. We do some autologous transplantation in CR1 mantle cell, very rare again, based on MRD.
This is one question I'm going to ask actually to Dr. Karfan later, because we had Professor Ermine who gave a talk in defense actually of autotransplant in mantle cell lymphoma, although we are well aware that some of these new fancy drugs are really giving great results in mantle cell. But I'll let you finish and then
I'm
back to this topic.
As I said, very rarely Hodgkin's or diffuse large B-cell, mantle cell, we do nowadays allotransplant. It's very uncommon nowadays. Yeah.
Annalisa, what are your thoughts on this broad landscape of immunotherapy?
Yes, thank you. So first, I concur with all my colleagues in really thanking all the participants to the IACH for the great spirit and motivation, and the interaction has been really tremendous. So regarding the role and the cell therapy in lymphoma, I agree that this is changing so much. So as Bipin was saying, the number of allotransplant in these patients is decreasing in a such important way. And what we see, it's also related to the fact that having more product, we can be more able to find the best product to our specific patients. In Italy, we have the possibility of using, of course, the 3 approved products, and we are, in view of the different toxicity, more and more in the always discussion between the selection of patients according to their age, comorbidities, even the presence of central nervous system involvement before the CAR-T. And again, as we have said, now having the place of bispecific, we can really open more and more the possibility for treating patients and identify the best therapy, of course, before or after the relapse, in order to assess the most appropriate treatment for those.
Thank you, Annalisa. So before, Mohammed, before I leave you go to your clinic, so I would like love to hear from you on the treatment algorithm in mantle cell lymphoma, because this is, I do remember from my medical school, it was considered as a terrible disease, a life-threatening disease, but now I think we're curing more and more of these patients. And of course, there's this controversy, BTK inhibitors, monoclonal antibodies, combinations, CAR T cells, but also what is the place or the role of auto-transplant? And I think outside myeloma, it's one of the remaining indications, at least according to Professor Ermin, who gave a very nice lecture in defense of auto-transplant in mantle cell lymphoma.
Thank you. I think that the best expression to describe what's going on in mantle cell lymphoma is the treatment algorithm is currently evolving. I would say that historically, chemoimmunotherapy, incorporating anthracycline and certainly cytarabine were the backbones of induction therapy, to be followed by consolidation with an autologous transplant, followed by maintenance with rituximab. So that was kind of the standard of care. This was challenged in a randomized study known as a triangle study, where bringing therapies such as ibrutinib to the front line were shown to have better outcomes compared to that standard of care. So that's the historic. This triangle study was, as you remember, a plenary session at IACH 2 years ago, and certainly have really invoked some serious thought about what should be the treatment algorithm nowadays. I would say that the advantage of transplantation has become the cheapest among all the treatments, consider comparison with all of these other therapies. So for treatment of mantle cell lymphoma in countries where there is limited access to new therapies, I would say that consolidation with transplantation should continue to be the case, to be followed by maintenance therapy with rituximab, as described by the study in the New England by Dr. Leguil and colleagues. So that's the algorithm. The challenge with these therapies is really a particular group of patients, which are those who have the high-risk mantle cell lymphomas, and those are typically represented by those with TP53 mutations. So I think that that's an area where, as you know, TP53 can induce resistance to conventional chemotherapy. And even with therapies such as CAR T cell therapy, the results appear to be slightly inferior compared to those who don't harbor that particular mutation of the TP53 tumor suppressor gene. So I would say that I don't believe that autologous transplant is dead for treatment of mantle cell lymphoma, and I concur with Dr. Ermin's assessment there. I think that in discussion with patients, certainly that's something to be considered. And I think that obviously the limited treatment approach, probably what would be happening in the future would be really adding maybe ibrutinib to that traditional backbone that was used for induction, and see whether that could even build further. So I believe that there is still a role here, and some patients may just go with that particular type of approach. But The benefit in patients who achieve deeper remissions has been questioned also by the IACH study, showing that perhaps that consolidation benefit may not be there. So there is a little bit of strong headwinds against auto transplant and how to really find the benefit. And I think the question here is, in certain cases where you have a deep response, is a transplant an over-treatment that is unnecessary or not? I think that's where the issue is coming to play.
But I think one of the arguments against transplant is about, unfortunately, the well-known toxicities when it comes to the need of hospitalization, mucositis, diarrhea. All of this in general would not contribute to great quality of life of the patient, to, let's say it like this. And of course, over the long term, if you're planning to cure these patients, maybe if, especially in older populations, the risk of secondary MDS. And actually, this quality of life issue brings me to another question now to the panel, because the transplant track as part of the ICH annual meeting was, I would say, call it patient-centric. And we had a lot of talks about the quality of life, survivorship, long-term complications, how to manage chronic GVHD, but also within the transplant procedure, how to try to minimize toxicities. And maybe Professor Nagler, you can comment on the talks that were dedicated to the choice of the conditioning regimen. I think Professor Blaise, who was our Rainer Storb Lifetime Achievement awardee, gave a beautiful plenary talk in the transplant workshop about the evolution of conditioning regimens in time.
Thank you again, Professor Motti. So as for we have 3 talks about conditioning. The first one was actually the first talk in the meeting by Professor Didi Blaise that got also an award, and he is one of the pioneers of reduced intensity and then a randomized study between myeloablative and reduced intensity, and 2, 3, 4 days of busulfan in which you participated, and then move to the haploidentical transplant, and now concentrate on the most important, I would say, one of the most important issue in transplant is the elderly patient or patients about 65, because the main indication today, you just asked about mantle, but I would say the main indication for allogeneic transplant today are AML, MDS, and myeloproliferative disorders. And the median age for all these diseases is about 70, 68, 72. So, trying to do, kind of safe transplant in this age is one of the major area in transplantation today, and Professor Blaise is one of the leader in this field. And so, I mean, of course, and there were 2 other talks by Ranier de Villiers from Marseille, but also from Alexandros Spalionidis from Greek, that established with the acute leukemia, the TCI, and then the TCI up to the age of 75, and now incorporate with Professor Annalisa Ruggeri, also the global TCI, in which he include also the post-transplant cyclophosphamide, post-transplant, and try to, increase the AUC of this TCI. So conditioning is important. We had some talks about mutation and conditioning. And so I think that refine the conditioning according to the age of the patient, and especially the comorbidities, is one of the most important things in transplantation, and we are not yet there, but we improving. And of course, for the survivorship and the long-term complication you alluded, so Professor Bidding Bipin Savani is leading the field. So yes, we concentrate about refining the toxicity, making transplant more friendly, and because this is where the field is going. Thank you.
Thank you very much, Aaron. And I would like to add that as part of this annual meeting and in line with all the efforts to make the life of the patient easier and more comfortable, actually, we had a unique special session where there was a live demonstration of the OBI, the on-body injector. This is a new method, next generation way of injecting antibodies and drug, and it's a specific situation. The first one to be approved, I don't know exactly, is the one with isatuximab in multiple myeloma. And we had a very special 45-minute session where the OBI samples were distributed to the audience. And I tested one myself and could show that how easy it is to circulate, to have a normal life while having these new devices to inject drugs. So let me switch again. So Bipin, Arnon mentioned the survivorship, long-term side effects, complications. What is the best of, and what's the take-home message when it comes to long-term survivorship?
So, take-home message. Let me start with we had a great discussion, great session. A complete session will be online. I think it's already online most likely. So those who want to go into the depth, please go and visit there. So my take-home message, survivorship clinic or late effect follow-up is a mandatory. It's a regulatory requirement because data support it increase the outcome, quality of life, and increase survival. Now, depending on size of our program, we can focus on certain things. But if we have limited resources, I would say infection prevention is most important because that drives the cost of transplantation. So infection prevention, how do we do? Using wisely GVHD medication, prolonged immunosuppressive therapy, particularly hydrosteroid, is a killer. It invites almost all late effects, psychosocial or organ-specific late effect. And we have 3 approved drugs for chronic GVHD. So you can use wisely and follow them regularly for post-transplantation for infection management prevention. How do we best prevent it? Vaccination. The evidence, we have a compliance rate of post-transplant vaccination of 95%, which increased from 45% 10 years ago, which help us less and less hospitalization by giving timely vaccination.
I'm glad you're mentioning the vaccination issue because, of course, we are well aware about some anti-vaccine movements, but these are life-saving procedure, especially for the highly immunosuppressed patient. And obviously, that's very important that all patients, especially now the flu season is starting in the Northern Hemisphere. So it's a call for action, sorry. So you mentioned, Bipin, the management of chronic GVHD, which of course is extremely important. And we had actually several talks and different sessions. And what I really liked is that the debate around chronic GVHD was driven by clinical cases, real-life clinical cases that were presented actually by junior colleagues. And this is really fascinating because not only they did the effort of going into these cases, preparing them, having nice slides, structure them into a nice discussion, but you could feel their capacity to be on the podium and to present. So I was very, very pleased to see this, and I think the field is in good hands. And of course, we discussed some of the advances in this field, not only now ruxolitinib, which is becoming almost an older drug in chronic GVHD, steroid refractory, but now we have some amazing data with ROCK2 inhibitors like belumosudil. And it looks like there is now a signal of efficacy even in lung chronic GVHD, which is, of course, great importance. But Annalisa, I think the best thing to do is to avoid chronic GVHD, although we would love to treat it efficiently. And I was happily surprised during this meeting to see the field of cord blood being rejuvenated. And this is, of course, very interesting because in general, historically, traditionally, the use of cord blood cells have been correlated with less chronic GVHD. And we heard from Professor Guy Sauvageau from Canada about this new technology for expansion, I think the UM71, something like this, which I think can be transformative despite the excitement around haplotransplant and post-Cy. So can you give us a brief summary about this and what's your view about the field?
Thank you, Mohammad. Yes, absolutely. So first of all, I'm also very pleased to remember that this transplant track has been also a joint venture between IACH and EBNT, because we presented also some experience from two working parties who were happy to join. So having this IACH as a really big community for a transplanter, I think this was also a great success for the joint activity that we can do across the society. So thank you. We were the first one, but I'm sure that we will have more and more of this kind of joint venture. And yes, we had during our meeting, we had different focus in, of course, the donor selection. You did a very fantastic presentation, very detailed, in the best algorithm for the donor selection. And also we discussed about the different GVHD prophylaxis, namely this new black, which is the post-transplant Cy. But regardless the fact that post-transplant Cy make transplant, especially those with HLA mismatch, very easy to perform and feasible, we should remember that the toxicity and also the risk of GVHD in the setting of adult patients more frequently transplanted using peripheral blood stem cell remain a main problem. So we gave the place to Guy Sauvageau and his team from University of Montreal to discuss about these impressive results. There is a recent publication on TCT 2025. Sandra Cohen is the first author and Mohammad Moti is the last, which is a comparative effort between the data reported using the UM71, which is a milieu of expansion for the cord blood cell, namely the CD34 cell, compared with the historical cohort. And this is important to clearly identify how the risk of GVHD is tremendously reduced using the cord-derived cell with a very fast engraftment within 21 days, we are not so very used to seeing cord, and therefore reducing the non-relapse mortality. And this is really the key, because there are more and more several findings showing the efficacy of cord blood transplant, especially in providing a strong GVL effect. I was personally surprised, and I took the photo of Guy Sauvageau showing 50% of event-free survival in patients with TP53 mutated AML, because it is, of course, a very severe and dismal prognosis. So we are very frustrating while still treating these patients. So we should more and more work and consider this as a true option. And I'm glad that the UM171 product, which is named Cell Pro, received the conditional approval from EMA on last August. So hopefully in Europe, we will be able to start using and become more and more able to dissect this strong GVL effect in the setting of cord. And also,
Arnon,
if I
please.
can say something that to me it was very, very interesting has been the session on ALL, in which we had, since the scenario of the treatment of ALL is changing with the use of CAR-T, also the new drug, we had a very, very interactive session with also the place of the consolidation with transplant for patients failing CAR-T, or for those patients having received a previous treatment with blinatumomab. And also we had very inspiring talk by the UCL colleagues on the TLL, which remain still an unmet need in our practice. And as you were mentioning, I was also impressed by the presentation of Professor He, also showing how we could, in a very fantastic setting, bring cell therapy in first line, which is, of course, difficult to imagine in Europe and probably US due to the regulatory things. But I think we should always consider that we should be brave and try to advance the treatment of our patients with the most effective line.
Superb. Thank you, Annalisa, for bringing this. And Arnon, you've been involved in this field for 35 years. So what's your view on the resuscitation of cord blood, and how is the field is going in terms of choosing the right stem cell source?
So thank you, Muhammad, and thanks, Annalisa. Yes, it was an exciting moment to listen to this talk and seeing again, that cord blood is still in several patients and several situations, and especially the ex vivo expanded cord blood that we worked on for so many years is really having these great results that Annalisa talked. And over all these years, we know that the biology of the cord blood is exciting, and actually from immunological point of view, the graft versus leukemia in cord blood is unique, especially in double cord blood transplant. Many years ago, a group from Netherlands shows a special CD4, cornolysine, special CD4 in cord blood. It was a blood paper, and then again from UK, Robert Wynn showed several papers about the unique GVL effect with cord blood, either after granulocyte transfusion and the group, and also Filippo Milano from Seattle, that shows that in AML, cord blood is able to clean MRD better than unrelated transplant and have a better survival. So there were all the time indications that the biology and the GVL effect in cord blood was unique, but then there was the story of engraftment and short-term toxicity, and now that we have this great data from Montreal about the new way to ex vivo expand cord blood, I think that this is very encouraging. Thank you.
So, Annalisa, before moving into the last topic, which I feel is also moving very nicely, and I'll ask kindly Bipin to handle the MDS topic, we have a question here from the audience about how can we explain that ex vivo expansion of stem cells, like what has been done in cord blood cell, can impact the immune reconstitution, immune recovery after transplant? What kind of data do we have today?
Yes, thank you. This is a very important question, and there are two different points. One is the optimization of the GVHD prophylaxis in CORD, which has been more and more discussed because, of course, at the beginning, having in a setting of high HLA mismatch, the in vivo T cell depletion was always performed impacting the immune reconstitution, but also in the setting of the expanded one, there is also the CD3 section of the cord, which is the non-expanded, that is injected, and it probably taking the advantage of the early neutrophil engraftment and myeloid recovery, enhance also the immune reconstitution. So there are several single center analyses showing actually the shortening of the hospitalization, the shortening of also the risk of not only febrile neutropenia, but also viral complication, which all of us performing cord blood transplantation know that there is, it's really one of the main problems. So it's really the possibility of having a better milieu, which allow the speed also in the immune recovery in the setting of the T cell compartment.
Wonderful. And I would say work in progress. Time will tell what's going to happen. In the last couple of minutes, I would like to ask Dr. Savani, because I attended myself the MDS, one of the MDS sessions, and I was quite amazed because, again, during medical school, I think MDS, we would say supportive care and transfusion, and that's all what we can. But this has been a very, very insightful discussion, and what I heard during session, debating through clinical cases, the issue of fatigue, the deleterious impact of anemia that we usually sometimes minimize or neglect. And we have now great progress in this, not only when it comes to diagnosis and accuracy of diagnosis and the role of NGS, but I think we have now alternative to EPO. We have new drugs being approved like luspatercept. Can you give us a summary about this? Because I'm sure the audience is interested. And obviously, anemia is encountered in everything we do, I guess.
So yeah, thank you so much, Professor Moti. So one of the best session, MD, I enjoyed, truly enjoyed. I'm going to review again by going online to review all the presentation again. So top summary, a short period of time. Number one, let's talk about low risk MDS. We have lots of good options now, and in the future also pipeline. So currently we have a EPO, most centers are using, especially those with financially constrained. We have luspatercept, a low risk MDS. We have a good coming clinical trial, elritercept, TGFP target inhibitors. So it's going to be good option there. And patient will live longer with great quality of life with improvement in hemoglobin, both RS negative, RS positive, low transfusion burden, high transfusion burden patient. High risk MDS, it's a graveyard for the clinical trial. 17 clinical trials failed so far in high risk MDS. We were very much optimistic about Verona clinical trial, which was just released the data, failed to meet the primary endpoint of overall survival. So we are stuck there with high risk MDS. But again, I would refer you to go to the online presentation. Very nice discussion about cytogenetic NGS classification and all the details. Thank you, Professor Mati.
Well, I think that was a very straightforward, clear summary. I believe we are coming to the end of this insightful roundtable. It's clear that the recent IACH 2025 Annual Congress has once again pushed the boundaries of education, innovation, but also collaboration in hematology. The data and discussions we have reviewed today highlight not only the remarkable scientific progress, but also a growing emphasis on translating these advances into real-world patient benefit with good quality of life. And I would put good quality of life in bold letters. So from novel therapeutic strategies to precision approaches, MRD, for instance, toxicity management, I think the field is moving faster than ever. And it is our shared responsibility to ensure that this knowledge truly transforms daily practice. I want to warmly thank all our panelists for their thoughtful analysis, and of course, our audience for joining us and contributing to this ongoing dialogue. So let's continue the spirit of the International Academy for Clinical Hematology, but also science without borders, knowledge in action, and always for the benefit of patients. Thank you, and see you at the next IACH activity. Take care.
Bye-bye. Thank you.
Bye.